I will now talk about the prevalence, assessment, and management of RBD. Now, in regards to our own experience at the Minnesota Regional Sleep Disorder Center, our timeline involved the formal identification and naming of RBD in 1986 and 1987. In 1992, we identified the strong association of RBD with narcolepsy and cataplexy. Also in 1992, we identified medication-induced RBD with fluoxetine and SSRI. 1997, we identified the parasomnia overlap disorder, which is a combination of RBD and a disorder of arousal from non-REM sleep, such as sleepwalking and sleep terrors. And then the very important topic in neuroscience took place in 1996 when we identified a conversion rate from idiopathic RBD to Parkinsonism, mainly Parkinson's disease and dementia of Lewy bodies. And then in 2013, we followed up our original series and were astounded to find an 81% conversion rate from idiopathic RBD to Parkinson's disease or dementia of Lewy bodies. Our colleagues in Barcelona, Spain, found an 82% conversion rate in their series from idiopathic RBD to Parkinsonism, virtually the same data. The prevalence of RBD is now known from 2 community-based epidemiologic studies to be 1%. The first study was in Switzerland that not only found a 1% prevalence rate in middle-aged and older adults, but they found an equal male-to-female ratio. Now we know that women with more mild RBD still have the same prevalence rate as men. The second study was from Japan, again, a community-based study that found a slightly more than 1% prevalence rate in older adult Japanese people. So really the 1% prevalence rate for RBD is equivalent to the 1% prevalence of schizophrenia worldwide. Now we do have a validated single question screen for RBD from a multi-center validation study, and this can be used in a variety of clinical settings. The question is this: have you ever been told or suspected yourself that you seem to act out your dreams while asleep? For example, punching, flailing your arms in the air, making running movements, etc. If there's a positive response to this screen, then that warrants a much more systematic sleep medicine evaluation with the clinical history, and then the gold standard would be polysomnography to document the loss of Ramelteon in the sleep lab. In terms of the treatment of RBD, the American Academy of Sleep Medicine published in 2010 in the Journal of Clinical Sleep Medicine the, quote, best practice guide for the treatment of REM sleep behavior disorder. First of all, you must protect the bedside environment. You want to remove any bedside table or any other type of objects that could cause injury. If you fling out your arm, you don't want to hit the corner of a table that could cause serious injury. You don't want to sleep near the window, which could be really devastating. I already mentioned that study showing defenestration or near defenestration from people sleeping near a bedroom window. Now, there's some tips for patients who live in long-term care facilities or nursing homes who may have RBD. Obviously, protect the bedside environment, but also use bed rails. You have to use common sense and look at the bed as a potential lethal situation for the sleeping patient of RBD and protect the bedside environment. Some patients even put pillows on the floor by their bedside as well. Now, there's 2 first-line medication treatments with between 80% and 90% published efficacy. First of all, clonazepam, which was the medication we identified in our initial series, anywhere from 0.25 milligrams to 2 milligrams at bedtime. But also melatonin can be very effective, and usually in higher doses, up to 15 milligrams at bedtime, or the combination of clonazepam and melatonin. For RBD patients with Parkinson's disease, in 2016, a Japanese study identified Ramelteon as being actually quite effective. The Ramelteon is a selective melatonin 1 and melatonin 2 receptor agonist. So I think we should consider Ramelteon in older patients with RBD alone or in combination with Parkinson's disease if clonazepam and or melatonin are not effective or are not tolerated. Now, a question that's frequently brought up that I think is a very important question is for patients with treatment-resistant depression who finally found an antidepressant that worked, that may have stopped suicidal ideation or major life dysfunction related to major depression. That patient and the treating psychiatrist, they don't want to give up on that medicine because of RBD being induced. I would agree that you need to keep the patient on the life-preserving, life-enhancing antidepressant medication, and then you treat the RBD. Even though the offending agent is still being taken, that offending agent for RBD is critical for quality of life and saving a life in a severely depressed patient. Key points. First, the prevalence of community-based polysomnography-confirmed RBD in middle-aged and older adults is 1%, comparable to the prevalence of schizophrenia. Second, a validated single-question screen for RBD has been published, which can be utilized in a broad range of clinical settings. Effective pharmacotherapies of RBD exist, although protecting the bedside environment remains of paramount importance. And in particular rare cases where you cannot really think about switching to another antidepressant, then you treat the RBD while the offending medication continues to be taken. That will result in a positive outcome across the board.